So thanks for that introduction, and I thought I would play to the fact that I've returned to Flinders after 15 years elsewhere doing other things, and really have a look at child obesity from, what can we learn from the past and opportunities for the future. And, the average time between research translating into practice is on average about 40 years. So, I'm talking about 15 years of past. So while there are some challenges, I'm hopeful that I'm only halfway through that and that we've still got a long way to go. I guess just to say that I'm also representing nutrition and dietetics within the College of Nursing and Health Sciences here at Flinders Uni, and I'll be drawing on research from a range of people from the Children and Families team, which has been going for about 15 years here at Flinders Uni. So I guess just to remind us of the sort of monitoring, what the monitoring says in terms of rates of obesity in Australia. So we've got about almost 2/3 of our adult population classified as overweight or obese, with consequence in itself, but also as a key risk factor for some of the big wicked challenges that we're facing in our healthcare system. And some monitoring data which looks at the PHN areas, places South Australia either on sort of benchmark nationally or above the benchmark in terms of prevalence rates, depending on geographical location, whether that's the metro or regional PHN areas. The good news is when we look at child obesity rates, South Australia has one of the lowest prevalence rates nationally. And I think that in part reflects some of the community-wide prevention focuses, the Eat Well, Be Active and the OPAL, of which Flinders has been heavily involved, in nutrition and dietetics, both in the interventions themselves and the monitoring and evaluation of those. In terms of that lower prevalence rates, that's good news. And I guess, why do we care about child obesity? And I just put these trajectories, or the BMI percentile charts, to remind us that the definition of overweight and obesity in childhood are the trajectories that mean the percentiles that when you turn 18 relate to being classified as overweight or obese as adults. So that the children of today are the people in acute care services, outpatients, chronic disease management clinics of the future, and that we want to shift those trajectories. And we're talking about over 1 million children around Australia. So my PhD back in 2001 was the feasibility study of what has then gone on to become the PEACH program, which stands for Parenting, Eating and Activity for Child Health. And it aims to support parents to achieve a healthy growth with their children, taking a whole of family approach that attends to the lifestyle behaviours, but also skill development, and uses general parenting skills training to do that. So in the same way that we use skills to help children safely learn to cross roads or tie their shoelaces or brush their teeth, that these same parenting skills can be applied to things like setting limits on screen time, or making sure that there's food available that are healthy choices within the thing, and a strong focus on problem solving. So I guess when I started my PhD, where were we at? Well, in the research literature, the dominant treatment approach was based on a child-focused intervention, and it was based on a diet, and it was the traffic light system. So it was actually putting children as young as 4 on calorie-restricted diets and placing the responsibility on the children themselves, for the most part, to execute that diet. We had a WHO document, and we had a national document called Acting on Australia's Weight. We had a national inquiry into obesity, and we didn't have any clinical practice guidelines in either children or adults at that time. So my PhD supervisors, Lynn Daniels and Anthony McGarry, they started with the research questions of could we use parenting skills as a strategy to manage overweight in young children? And over the course of the early 2000s, 2 randomised controlled trials were undertaken to test that hypothesis. And what was novel here was that it was parent-led. The agents have changed and the responsibility was placed with parents, but also it was a lifestyle approach. So it was implementing the dietary guidelines and implementing the physical activity guidelines and being underpinned by these general parenting skills. And what was very interesting is that the graph up on the screen now shows that it achieves similar rates in terms of end of intervention effect at 6 months, but unlike this previous approach of the traffic light diet, there was actually a sustained impact through to 2 years, where previously you saw over that period of time a return to baseline levels. So it seemed to be a more sustainable approach. And the types of reductions in BMI Z-score after 6 months was around, consistently around 8 to 10%. So then the question became, well, how can we look at putting this into practice? And so there has been, both in South Australia, but also an opportunity in Queensland to see if this program can be scaled up and implemented at a statewide level. So there was the Peach in the Community study here in Adelaide, which again looked at, instead of being in a research setting and research interventionists, training program facilitators, which was also the model that was used in Queensland. And in Queensland, it was a statewide community setting, evaluation data over 1,000 children. And again, it was looking at training local facilitators to deliver the program. Unfortunately, or perhaps not surprisingly, once you were looking at that at scale, the effect size was down to less than half, or about a quarter of what we saw in those strict randomised controlled trials. And so I think that speaks to both sort of initial effectiveness of the program, but also the training models, but also what we are now calling, back then we didn't necessarily have the term for it, but those implementation science, the translation science, so all of the system factors that also are at play there. Now in 2018, we're having an obesity inquiry nationally. The good news is we do have clinical practice guidelines for both adults and children. The standard is this family-focused approach, but now the question is, how do we continue that path to influencing practice? And I guess that is all sort of embodied in the WHO report around ending childhood obesity, which has a recommendation to provide family-based, multi-component lifestyle weight management services for children and young people who are obese as one of the key recommendations. So some of the next generation research questions is also how can these programs be tailored but for specific populations? So there's high prevalence rates in adolescents, in certain categories of disability, as the first slide, rural and regional areas. So there's a lot of work to be done around how to tailor these programs for different populations. If we say that going from the research setting into practice, you're going to get some loss of impact, how can the program impact be enhanced in the first place? But also, what are the opportunities to integrate into existing services, have more of a co-design approach rather than something being developed in research and then rolled out. So as we've heard across the week, this starting together and looking for opportunities there. I guess now this is the work that's been done in the Children and Families team within nutrition and dietetics from a range of different angles. So we've got people working in terms of digital health interventions in adolescent populations. We've got a strong focus on other carers, so not just family. So carers might be with young children in early care and educational services, or carers in terms of grandparents, and starting to look at some intergenerational obesity prevention. And we've got a whole range of sort of research platforms in terms of systematic reviews, simulation modelling, really bringing in strong behaviour change science to see if we can get better intervention design, and then working with different stakeholders in terms of looking at how you would roll out or integrate and evaluate these interventions. So that was sort of the past, and so now I just want to give you a bit of a taste of the future. And this is really, promotion in terms of come and talk to us if there are, if you're from FMC or from SA Health or Primary Health Networks or local councils or a digital provider. We want to talk to a whole range of stakeholders about how some of the work we're doing around intervention development design might be applied in different contexts around looking at novel opportunities for obesity prevention and obesity management. So one example is led by Professor Michelle Miller and funded by a Heart Foundation Vanguard grant. And it's called, and also Ivanka, who's in the audience. So this is the HOT project, which stands for Health Online for Teens. And I guess the context, so there's similar rates of obesity in Australian teens, but we also know that as children go through childhood and into adolescence, that propensity to track into adult obesity and associated health risks, including cardiovascular health risks, strengthens. And it's a critical period. It's a period of sort of rebellion and freedom and independence, but perhaps also things that had happened in people's families. It's also an opportunity for them to start forming their own health behaviours. So it is potentially a challenging but pliable period of transition. The family is still important, but there's increasing independence and autonomy around lifestyle behaviour choices. And a systematic review published this year really highlights a lack of effective programs, a very underserved population in terms of interventions at all and effective interventions. And perhaps we use the propensity for engagement in technology to be a leverage point, even though it can be seen as a problem sometimes. So HOT is an evidence-based online program. It's also a good example of the college restructure and engaging in multidisciplinary research, going beyond nutrition and dietetics. So the intervention is developed and supported by a panel of experts, both from psychology and human movement, as well as nutrition and dietetics. So a strong theoretical underpinning, and it involves self-paced models and uses some specific techniques around goal setting and peer support. And there's also some innovative digital technologies such as the HotBot in terms of having a artificial intelligence-driven conversational interface. So this study is being undertaken this year, and at the moment it's a feasibility study where they're looking to see if you can recruit adolescents, so 13 to 17-year-olds, how they interact with it, and then some focus groups as well, so sort of underpinned by a mixed methodology in terms of the monitoring and evaluation framework. I guess something that my research has focused on over the last 5 years or so is really the elephant in the room. If we look at programs like OPAL or some of the sort of state or national initiatives around the nutrition messages, They might be, drink water or eat vegetables. There might be a switch message, so switch cakes for yogurt. But really, very little is being done to directly tackle this type of statistic where we've got over a third of our energy intake coming from what we call discretionary choices, which are the energy dense, nutrient poor, placing at risk of both excess energy intake but also excess sodium, added sugars and saturated fat intake. So some of the work that I've been doing in this area is saying, okay, well, there's a range of policy levers, so we could use taxation, like there's the discussion around sugary drinks tax. We could look at reformulation through things such as the health star rating, and the hypothesised mechanism is that will change consumer behaviours and have impact on dietary intake, adiposity and other health risk factors. However, the bit in the middle in terms of the dietary strategies is really a black box. So in terms of the strategies that have the potential to modify discretionary food intake and change energy and nutrient intake, doesn't have a strong evidence base. And so working with collaborators at UniSA, we have a really nice platform to be able to do dietary simulation modelling. And if anyone wants to do dietary or lifestyle simulation modelling, this platform can bring any data set into it, and it has the interface to be able to say, well, if we change this, what is the impact on population intake or sample intake? So it's a really unique way, a novel way to be able to get the data before you might invest in the expensive community or randomised controlled trials. And so we compared, so kind of a stop-it message, so around moderation of discretionary choice, that might be only having biscuits with your coffee every other day, or only having one Tim Tam instead of the whole packet. Substitution, so that idea of switching from discretionary choices to the healthy, from within the everyday Australian Guide to Healthy Eating choices, or reformulation. And not surprisingly, and as hypothesised, moderation does have the biggest impact both on those nutrients of risk, but it really is the one that if we're going to get serious about moderating energy intake, that is the message that would have the biggest impact. However, substitution, so even getting people to, so we matched it so that you're not going to go from eating a 20-gram chocolate bar to 20 grams of apple. You would eat a whole apple. So we factored in realistic food choices, and again, makes a moderate impact on energy and quite a good impact on the other nutrients at risk. But in terms of reformulation, so some of the dominant strategies at the moment, while it has quite a good impact on some of the other nutrients, it really isn't a good strategy as part of obesity prevention. So just to highlight, so there's these new areas of investigation and feeding into those next generation research questions. And next year, we're going to undertake a study which we're calling Thinking Outside the Box, and really having a look at what are some novel touch points for obesity prevention. And the key questions here are, how do we support health professionals to support parents and caregivers? What should the messages be? We know that sometimes engagement is a real barrier to the success of service provision. So how can we raise awareness and motivation to engage if services were available? And what are the opportunities, instead of having it as a standalone service, to integrate child obesity prevention into existing structures, which might be traditional health services, or it could be something like a library program in local councils. So we're being really open, and we want to work with a really diverse range of stakeholder groups, and particularly sort of non-traditional or non-health. So if you've got, if you're from a stakeholder group, or you think that this would be an interesting, some questions to explore, we'd love to hear from you and have you participate in this study next year. So thank you, and please get in contact either through Twitter or via email if this is something that either through SA Health or Salin or across the college and the university. I'm new, I want to talk to people, and I'm open for collaboration and support, so thank you.